Historically, 10,000 was used as a threshold for treatment of GBS, asymptomatic bacteria, during pregnancy. However, the efficacy of treating asymptomatic bacteria with low colony counts is controversial, and the data appear limited or contradictory. Like many things in medicine, it's nebulous, needs more research, but it isn't necessarily so. The question is, how do you know and how do you don't know? And that's where the patient has to make the assessment of which risk do I prefer. Do I prefer a risk where I have asymptomatic bacteria, evidence isn't clear that it's going to risk me out for preterm labor or premature rupture of membranes or pyelonephritis or whatever, but I also don't want to take antibiotics. And I understand why they don't want to take antibiotics anymore, partly because the trust in medicine right now is at an all-time low, and they're overprescribed and overused, and they do alter the microbiome for you and potentially for your baby, which we know is so important.
And potentially create resistance when you really need it, because sometimes you really do need antibiotics. It's, can be very helpful. So you don't want to overuse them just because they give them out like candy.
Yeah, this gets me off on my tangent about the model of care that doctors have to practice in, which is this volume-based model, where they don't have time to sit down and have a long conversation with a woman about watching for this and doing for that. It's just easier. You got a positive culture. Oh, I'm going to write you a prescription for penicillin or ampicillin or whatever I'm going to write you for, and I want you to take it for a week, because it's easier to do that.